Good afternoon, everyone. My name is Kenneth Paik. I am a third-year medical student at UAB Hearsink School of Medicine, and today I'll be talking about a patient case report regarding the reversal of brain death, or what we like to call. So this is our table of contents and what we're going to be discussing for today. And we'll go ahead and get started with our patient, who is an 18-year-old female and presented to the emergency department with a devastating gunshot wound to the head, GCS score of 6. She was initially declared brain dead by the neurosurgeon who was on call. This was after we checked brainstem reflexes, such as the pupillary light reflex, corneal reflex, the oculovestibular reflex. However, she did retain cough and gag reflex, which led to some questions in further studies. The doctors who were taking care of this patient decided to order a nuclear medicine study, but found that there was negligible intracranial blood flow all throughout the sagittal sinus. That was a very poor prognosis for this patient, which led to the declaration of brain death. However, with the gag reflex still intact, the family were still questioning if their daughter was still alive. So they transferred her to another hospital at the request of her mother for a second opinion. So what is brain death? It is an irreversible cessation of all circulatory functions within the cerebrum and the brainstem. This was first pretty much coined by Mollaret and Goulon, who had a patient back in the 1950s who was apneic, comatose, no brainstem reflexes, no activity on EEG. So this term brain death is defined pretty not too long ago, which calls into question what that actually means, and a lot of controversy that is sparking in today's conversations among neurologists. And to give a little bit of background of what brain death is, it accounts for about 2% of deaths in the United States, so a pretty large, significant portion of deaths. Again, it's the irreversible termination of brain function, both in the cerebrum and in the brainstem. The issue with this term is that there's no regularity to confirm brain death among different institutions within the United States. There are steps that we can take, but there are a lot of irregularity and a lot of opinions on how we should perform these diagnostic tests. So there's no perfect test to document whether a brain examination has been confirmed and documented for each patient. Lots of limitations. Again, for example, the technique in which we perform the brainstem reflexes in the apneic test, different criterias are available per institution, leading to different types of diagnoses and potential misdiagnosis of brain death between physicians. Another limitation is that there are confounding factors that may actually mimic brain death, like if the patient has an electrolyte imbalance, if they're hypothermic, or if they're intoxicated on some sort of drug, that may also impair the brain death examination. And finally, when we have ancillary testings and confirmatory tests like EEG or angiography, those tests in itself also have potential false positives. There's no perfect test for this. And so it really comes into question what we should do about all of these patients who are misdiagnosed with brain death, especially for our patient. So for our patient, we checked the brainstem reflexes, we did the nuclear medicine scan, and we also did a CT venogram, which showed no negligible flow throughout the brain. And the nuclear medicine scan also showed no evidence of radiotracer accumulation throughout the sagittal sinus. So a pretty clear picture that this patient, despite having other normal functions, should be declared brain dead, right? However, at the transfer of the patient to the new hospital, before I get into that, this is the images with the nuclear medicine scan. As you can see, there's no cerebral perfusion, both on the anterior and the lateral parts of the head and neck. And this is the CT venogram that did not show any appreciable intracranial blood flow. The patient did get surgery and did get a repeat CT angiogram which was shown by the radiologist to have some appreciable intracranial blood flow throughout the sagittal sinus, and no major evidence of sinus injury. And as you can see, the left and right ventricles are more appreciable with no mass effect. So the hospital course of this patient, she received a craniectomy at the consent of the family, and a few weeks later, her neurological status actually showed improvement. She began to follow commands like squeezing the nurse's hand and actually responded to peripheral pain response, which was not demonstrated at her first initial presentation in the ER. She had improved brain stem reflexes like the pupillary light and pointer reflex. She even began to speak single-worded phrases and has a GCS score of greater than 8. She initially presented with 6. And the patient was then managed with standard hospitalization procedures like an IVC filter, a trach, and a PEG tube. And with all these measures in place, the patient actually improved in her function and her neurological status. So what does this mean for the brain death examination? Again, it can occur by devastating injuries to the brain like TBIs. But there are lots of studies in which demonstrate nuclear medicine scans and CT angiography demonstrating 100% sensitivity and specificity, which is not exactly the case as seen as our patient who did recover from the initial examination of brain death. And despite the initial imaging findings, as evidenced with the new CT angiography, she did recover. And as I mentioned before, she did start to show neurological improvements. She got her reflexes back. She was showing signs from the pain response. And so in our opinion, and for the case of this study, we do think that this was a premature decision to call her brain death. And that was good news to the family. However, it does call into question if this brain death examination is viable for all patients that come into the hospital. For example, the Journal of American Medical Association reviewed 200 patients in which they were diagnosed with brain death, but 6% of them still showed some brain activity. So those patients were not truly brain dead. Another journal in internal medicine studied 500 patients, and 12% of those patients had residual brain activity, demonstrating that that examination was also inaccurate. So the lack of consistency leads to inaccurate results, and really it is critical for us to evaluate how we want to perform this brain death examination, and it's crucial that we make improvements in both accuracy and standardization across the board amongst all hospitals to really capture all patients and not leave any of these patients behind and misdiagnose them with brain death. And I'll take any questions.
Was EEG ever?
So she didn't get the EEG. They did other ancillary studies like the nuclear medicine scan and the CT venogram. So that is what they called enough to declare her brain dead. I guess the question is, should we perform more tests like the EEG to catch those small minority of patients, or is that too much testing where we're not going to get the accurate results? So she didn't get an EEG.
In my day, that was the number one thing.
That was the number one thing.
Before you would actually.
Mhm. So she eventually passed away, but she had 3 more months to live in terms of her respiratory function. So she was placed on a ventilator, but then transferred to a tracheostomy, and she was able to breathe on her own. Again, she was responding to painful stimuli, which she wasn't before. She had all of her reflexes back, and she was saying single-worded phrases like mother, father, with her family in the room.
Is there a time component to the diagnosis of brain death?
That's something I probably should have looked up because I'm not really sure. But I assume in an acute setting like this, a gunshot wound to the head it should be no later than just a few days after these positive tests. I think awareness is definitely the primary goal of this, as well as figuring out if we need to do more ancillary testings, really just at the sake of the patient's family, because this was the patient's mother who led the daughter from one institution to another, and that's how we got all of these, all this information from. So really glad that you brought that point up, and I also agree. So it was brainstem reflexes, it was the apneic test, where she wasn't able to breathe on her own. So that itself was enough or sustainable to declare her brain death in terms of the diagnostic criteria by the neurologists. But because that she had retained the gag reflex, the cough and gag reflex, that further warrants other studies, like the nuclear medicine scan. So once you get to the stage of nuclear medicine scans and there's no cerebral perfusion, that's pretty much enough to say that there's no more function in the brain. But the patient undergoing surgery, removal of brain tissue that was edematous, showed improvement. So really, we think that the nuclear scan study was a little bit too premature, or it might not have been accurate, and it was just a false positive. I think at that point, it's just really for the family. So this patient did get to go home and live that last couple of months with her family, and I think that brought a lot of peace with her parents. I think she was there for, it was less than a week after she did all these ancillary tests.
Were any nuclear scans redone after the initial one? They saw some improvement.
No, so the studies show that nuclear scans and cerebral angiograms have the same sensitivity and specificity rates. So it didn't warrant for any second nuclear scan, because she did get an angiography.
I want to tell a funny story. I was in medical school, when you were going through your ophthalmology, and a patient died, they would tell you to look in the pupil because it's completely dilated. You could do a good exam, you see the retina. So one of the students was examining a patient that had been declared brain dead and was lying on the gurney and looking in the eye, and they're getting a good experience. And then all of a sudden, that patient sat straight up while the medical student was looking in the eye. Well, I think that was the most top, I think he's still running. Anyway, eventually the patient died, but was not quite there yet.
Right. Oh, that's funny. Well, thank you very much.
All righty, thank you.